So I don't know if you know this lady, she's Eglantine Jebb, and it might not be. It's not great to start with the opposition, right? But this lady, in the aftermath of the First World War, founded Save the Children. And, said lots of things, and in various forms was famous for saying every war is a war against the child. And I feel like I'm teaching the room to suck eggs here, because you know this better than I do. But she was a formidable woman, and in the aftermath of that war, she raised money in the UK to feed starving children in Berlin. So the will and the effort has always been there, and we should try and remember that we need to continue that effort. Also from Save the Children, I would recommend this report to you, The Child in Modern Warfare, which we've just touched on in the introduction, and the escalation of the size of this problem, which continues to rise. We've seen a threefold rise in serious conflict in the last 15 years in the world. And it's highlighted 5 key kind of themes, if you like. The rise of new weapon technologies that specifically target and harm children and make them more vulnerable. The unprecedented severity of child injuries and deaths, which we know very well of. The numbers are incredible. And the normalization of this civilian harm, which we inevitably get worn down by. We see it so much that it just becomes part of the background noise. I mean, we can talk about Gaza, but we know that in the background of Gaza, while that's been dominating the news, there are many other areas that we just don't hear about. And I'm sure you do. But sitting in Bristol and looking at the newspapers, we don't talk about Myanmar, we don't talk about Sudan, we don't talk about any of these areas, and it has become part of the background normalization of what happens. Coupled with the loss of any protection in terms of discrimination, etc., in what we would call military principles. And the crisis of accountability, no one has held anyone to account. The withdrawal from treaties on various weapons, and then leading into the long-term social costs. We know that millions of children have been injured and killed in war. We know that tens of thousands have been injured and killed in war in the last 24 months. Those children have been lost to society and lost to parents, but the burden and the social cost of the many that have been injured and survive is what we need to focus on and think about. So what is blast and why is it different? Okay, so the predominant mechanism of injury in conflict for a child is a blast injury. Now we can make it very different and we can think about it simply. The major difference is the primary blast injury mechanism, which is the one, as clinicians in Bristol or in South Africa or anywhere else in the world, we very rarely see unless there's a civilian blast event, which is relatively uncommon. The rest of the mechanisms should be relatively familiar to a trauma expert. Ballistic trauma, penetrating amputation, blunt trauma, traditional trauma that we see in many mechanisms. And then there's the thermal, which is predominantly heat burns, and then the long-term effects and the coronary effects. But the primary injury is what we're not used to seeing, and it's something that we need to be familiar about. So I'm not going to give you a physics lecture on blast trauma, I don't have time, but to put it into visual context for you, this is the primary injury.
5, 4, 3, 2, 1.
The fuse races towards the site. In 1,000th of a second, the gunpowder ignites. In 1/1,000,000th of a second, it changes from solid to gas. And there, finally, we can see the shockwave.
Okay, and that's the mechanism that you're not used to dealing with, the primary blast injury wave. That is the delivery of energy to the body as that overpressure of air moves through that distance away from the explosion. That's the mechanism that causes the injuries we're not used to, like primary blast lung, primary blast gut. It has a physical and cellular effect on every part of the child's body. We need to be aware of that when we assess children, because you will see children occasionally without any sign of other injury, but just with primary blast effect. And that is what makes blast different. But never mind the differences, the rest of blast is traditional, penetrating, blunt, and thermal injuries that many of you will be familiar with. Now, let's go back to the numbers. That's the only clinical stuff, and there are no horrible pictures, so you can relax. So we've already mentioned this, 500 million children living in areas where they're at risk of a conflict injury, which is 1 in 4 to 1 in 5 of the world's population, child population. When we started working on our blast injuries resources, which I'll come to, about 170 million children lived in high-intensity conflict zones. That will be north of 200 million now. This is probably an old figure. And we know that 50,000 children killed or injured in Gaza in the last 23 months. So the scale is epidemic, okay? This is a public health problem. If this were a virus, we'd be in lockdown. And it's not addressed in the same way. We don't see it as a public health problem. We need to deal with it as such. One of the challenges is that we don't have the data. Okay, we don't collect data. It's hard to collect in the areas where it's accessible, where it should be collected, and we don't pool it and we don't collaborate with each other. Well, we do know some data. Okay, so the Joint Trauma Theatre Registry, which had an entry for every patient that passed through US and UK military facilities in Iraq and Afghanistan, collected lots of useful information. 25% of the civilian patients that entered into those facilities were under 15, and 50% of those were under 5. So it gives you an idea of what your patients are going to be. We also estimate that, and again, these are the survivors, 85% of critically injured children die in the pre-hospital phase, so they don't survive to whatever health facilities are available to them. Now, if we're going to focus our resources on our simple interventions, then this is where we might need to think about how we do that, and I think Tim might mention something about this later, so I won't say much more. And then the effects of injury to these children is a social and lifelong consequence for them, their family, their society. So we know that 40% of children injured by legacy or landmine devices never go back into education. They never get educated. They're now restricted in their economic output, and they become an issue for society themselves for the rest of their lives. What do we know about blast injury characteristics? So if you're setting up your facilities, how are we going to deal with this? We know that there's an all-cause mortality of 8% in hospital. Okay, so those are the children that survived in hospital. Again, this is Joint Trauma Theatre Registry information. That's 8% in what was at the time, and probably remains so, the most capable trauma system that the world's seen. A trauma system that the vast majority of children would not get to enter, and a trauma system that had trained people used to an extent, dealing with it. And we also already touched on, most paediatricians don't do trauma, most trauma people don't do pediatrics. Now, I stand here as an expert, but a relative one, someone who's seen slightly more blast-injured patients than others. Okay, and there are people in this room who have seen way more than me. They're multiply injured, they're easy to injure. The energy and the proximity of everything, because they're small, means that they get multiple organ injuries. So most of them that come in surviving are critically injured, but have multiple compartment injury. Burns is predominant in 70%. Penetrating injury, because of the nature of their bodies, is high. And they have double the requirement for emergency surgery than adults, versus the non-blast mechanisms. The principal cause of death is burns. Now that is probably because in those circumstances, if you have 40% burns, you're not going to survive because you simply don't have the ongoing care that you need to do that. So these are very difficult futility decisions being made on children with relatively small burns. And 30% are critically injured, 30% are severe and 18% are critically injured. So there's a very high burden for that health facility. Now you might be saying these are military figures, right? So they're not comparing these to soldiers or combatants, they're comparing these to adult civilian patients in the same setting. So we're at the same vulnerability, but not wearing body armor, etc. So children are different, yeah? They're not small adults. We like to say that a lot. And they're different and more vulnerable for lots of different reasons. So first of all, their patterns of life are targeted. They play, they socialize, they go to school. When something goes bang, it's usually a group of children that are injured. They're exploring things, they're picking them up. They're unable to assess the risk around them. They're not educated in risk assessment. We spend 1% of I'm going to say the wrong word, but 1% of demining or removing that kind of risk from children is spent on their education, compared to a higher spend on adults. Okay, they're physiologically and anatomically different, so they're much more vulnerable. Okay, their bodies are smaller, their bodies are easier to penetrate, and lower injuries. These are weapons designed to penetrate armor and adults. The impact on their health, or on sanitation, etc., is huge. So clean water, their education, and then the long-term impact on their mental health. They are developing young adults. They're not formed products like we are. They are going through this, and this is what they will become. So the mental health education outcomes are severely impacted. So all of these things make them a very special and vulnerable group. But, now, I apologize to paediatricians, of which one I count myself. The challenges are huge, okay? And we have various areas that I'd like to focus on. We've mentioned the emotive challenge, okay? Now, when you see a child with 3 limbs missing in front of you and you're a parent, you're a father, you enter into that emotional window. You look at that in a different way. It presents psychological barriers to you. You don't have the skills, okay? You fear treating that child. You're an adult physician. You're a pediatrician who doesn't do trauma. No one's taught you how to do what you need to do. Doing the basics right is critical, because we're not trained. We have a moral imperative to train our people who are dealing with injured children to do it. Okay, a strong theme. If you interview or poll people who are deploying in military or civilian settings, what are you scared of most treating an injured child? The moral injury you will cause your staff by not preparing for that is very significant. Pain, we've mentioned a couple of times. We don't do pain well. We don't do it anywhere well. We don't do it in Bristol well. We don't do it in London well. We don't do it in anywhere. So there's some we need to make pain a better thing. Okay, the outcome of untreated pain is poor healing, is psychological, is chronic pain, is mental health, is socioeconomic disaster. Okay? We need to make pain matter. We need to make it visible. We need to understand it, and we need to treat it better. Okay, and all those things are well described in the Lancet paper. And we can do it. Okay, we can do it. How many of you used intranasal fentanyl? How many of you have never heard of intranasal fentanyl? Okay, in that case, the numbers of people putting their hand up should be much higher, because you can treat pain simply, safely, and cheaply anywhere in the world with something stuck up their nose. Okay, children, okay, different but also the same, right? So we're all scared of children. This is my son. He has given consent by implication of being my son to be in that slide. And he's scary, okay? Most of you are not pediatricians when you deal, most of our people who meet an injured child aren't pediatricians. If you woke up as a family doctor in Ukraine 4 years ago, the next day you were a trauma doctor. Okay, and if you're a pediatrician, you're a trauma doctor. So we like to be scared of children. We like to tell people that they're different. We have speciated the child for a generation of pediatric training. What they are most definitely not, though, is an octopus. Okay, they are the same species as every other patient you have ever treated in your life. We absolutely have to empower each other not to be afraid of the child and to treat the child. No one else is going to do it at that time. If you're an ophthalmologist or a pediatric trauma specialist, you're the person who has to do it at the time. So what can we do? Well, we can think about the numbers. Okay, I'm not a humanitarian. I've never deployed. I've never had to make the decisions you do. Trauma and this is all trauma in all age groups. Trauma kills twice as many people nearly as HIV, TB, and malaria put together. But it gets 1% of the global health investment that those 3 conditions do. Now, I'm not saying that that's not a good investment, okay, the 36%, but it feels like we could be looking at this in a different way. This is a public health issue. $7 per life year saved for a trained first responder slash paramedic, whatever that definition might be, versus $922 per life saved for HIV and AIDS. If you put a paramedic on an ambulance, $94 per life year saved in trauma. These are very compelling numbers, and I think we need to think about that. We need data. It's already been mentioned. We need to agree what data we have. There's no common data set that we collect. We need to share it and not stick it in our back pockets and use it as organizations. And we need to make it relevant, okay? We can collect data and ask questions of it, or we can ask questions and collect data, and that argument goes round and round and round between clinicians and academics. But we need to make sure we collect the data that helps us. What is killing children? I can tell you what it is. It's compressible. The commonest cause of death in conflict injury is compressible peripheral hemorrhage that I could teach every person in this room to prevent or stop today before you left. What about civil resilience? Why can't we teach other people to do this as well? So in the UK, if you have a heart attack and you collapse in the street, there's a good chance that someone's been taught layperson CPR, and that a school child might come and do some compressions for you while the ambulance is being called. If you're stabbed in the street, you might run to the nearest stop the hemorrhage box, and someone might stop your hemorrhage. They might go and grab a defibrillator to treat your VF. We should be thinking about simple measures. Would it be so crazy to teach everyone who deploys to a conflict area to put a tourniquet on? A piece of kit that can cost as little as $2 or $3. Or to compress junctional hemorrhage? Or to teach school teachers to do it, or the population. The person who saved the soldiers and the civilians in Afghanistan and Iraq was not the complex healthcare system, it was the person who put the tourniquet on, the person next to them. We can provide resources. Now, this is the Paediatric Blast Injury Field Manual, which was written for Syrian clinicians. It was the first piece of output we had. If I could have my way, I'd just take the blast bit out and just call it the Paediatric Injury Field Manual. It's a good piece of kit, and I encourage you to use it. And you can get it on that scan me bit. And then pain, we've got pain management for injured children. And we can train, which we're going to do later. Did you give me time or 2 minutes? I thought it was my time, sorry, okay, beg your pardon. Pediatric trauma resuscitation course, 60 seconds, I'll be out of here, I promise. Which we're going to do, which can be scaled at any level, okay, paramedic to trauma surgeon. And then we need to collaborate, okay? We've got all the right people in all the right places with all the right skills to do all the right things, and we absolutely need to do that. And if you want to get in touch with me later, then there's my email, and there's our website, and I'll be around for the next 4 days. And I'm sorry I overran, but there we are.